Start.
Okay. Yeah. So welcome to the day 2 of e-workshop series on COVID-19. If you have any questions related to this session, please put it up in the Q&A section. There is a Q&A section down below where you can put all of your questions related to the session. There will be a Q&A round after the session. And if you have any issues regarding the audio and video of the webinar, please put it up in the normal chat box. Our IT support is there to help you on that. Now over to Dr. Sandeep. Thank you so much.
Thank you, Vishnu. Thanks to all the colleagues, those who have joined from the different parts of the globe today. Though we know that some of the colleagues are joining on the way because of the time zone differences. Today, to carry on our e-workshop series on COVID-19, today we are going to have a second session for the same, and the session is diagnosis and management of COVID-19 cases. Before I would hand it over this session to our eminent faculty, Dr. Vijay Neglu. He is based in Thane. He is an eminent expert associated with Public Health Foundation of India more than a decade. He is the director of Renuka Hospital for Advanced Diabetes Care, Dombivli, since 35 years, and director of Dr. Neglu's Diabetes Specialty Center at Thane and consultant diabetologist, Jupiter Hospital, Thane. If you see his current positions, he is a fellow of Indian College of Physicians, president of Neglu's Academy of Diabetes and Research, teaching faculty in Diabetology, College of Physicians and Surgeons, founder member of Association of Diabetes Educators of India, and earlier he was also the honorary associate professor of medicine at RGMC Thane, honorary physician and diabetologist at CSM Hospital Thane. He has extensive number of publications and he is a well-renowned speaker nationally and internationally. Today, why we have taken particular topic, the thing is that you know that how it took only 4 months for the corona cases to reach 1 million, and just 12 days the doubling has happened. Just imagine that how fastly the corona is spreading, and the role and availability of various drugs, if they are there, whether they have any role. There is a lot of conspiracy going on regarding the hydroxychloroquine also. Hydroxychloroquine, whether we do prophylactically or not, and you know that on the president of US, Mr. Trump, last week only requested India, Mr. Modi ji, to send the slot of hydroxychloroquine to US. So what's the role of hydroxychloroquine? There is a huge number of trials which are going on the vaccines also all across globe. So whether the role and availability of vaccine, where the globally we stand today in the vaccine race so far, and what has happened in the vaccine race so far, that is also the query. And I think today's session will try, Dr. Neglu will try to help all of you. And what are the various things which you are using into your own countries? It will be a great thing if we can also learn from you, because currently there is no standardized protocol for the medications which have come over, but hit and trials from the different parts of the world based upon the learnings of the few countries where corona cases have happened and where the recoveries have also happened. We are based upon that only, we are suspecting that these are the drugs which are probably can be useful. These are the things which can be useful for that. If you see the global scenario of coronavirus COVID-19 cases, we have already touched the 2 million mark, and the total mortality is around 1,23,000 cases all across the globe. And if you see in India, the total number of cases, we have surpassed 12,000 cases today morning, and we have a mortality of 414. But another side, we have a good news also, that around 1,500 cases, the recovery has also happened. So there is something which is working for the recovery of these patients. What are those things? That is the purpose of having this talk, the diagnosis and management of COVID-19 cases. And the World Health Organization on 7th April this year has put it up their theme also to support nurses and midwives, because they are the frontline warriors supporting us, putting up their life into their risk to support and protect the broader community. So they are fighting for all of us. That's why the World Health theme this time, the WHO has given impetus on supporting midwives and the nurses. So with this, there will be a question answer session at the last. You can put it up your queries into the question answer chat box, and Dr. Neglu will help us to whatever the queries you are having. He will help us to appraise all your queries regarding that. Over to Dr. Neglu, sir. Over to you, sir.
Thank you, Dr. Bhalla, for your kind words of introduction. very, very generous introduction. And of course, the introduction to the subject of the coronavirus as well. Now, our job is to start today the understanding of the coronavirus and the diagnosis and management, how you go about it, is what we're going to discuss today. So I welcome everybody all across the globe, people who have joined in for this interesting seminar on COVID-19 diagnosis and management. We know the cause of the disease is the coronavirus, which is shown onto the right of your screen. This is RNA virus, which has created havoc, so much so that the entire world is in the grip of this particular disease. So disease produced by coronavirus is what is called as the COVID. Coronavirus induced disease is what is called as COVID. And 19 stands for the year 2019, where it was first discovered. And that's why the name COVID-19 is the name of the disease. And SARS coronavirus 2 is the name of the virus, which, as I said, is a typical RNA virus, which has a coat and it also has multiple spike proteins. It also has a membrane protein and it also has envelope protein. And it has a tremendous propensity to infect the entire world, and it is very obvious by the figures that Dr. Balla mentioned just now. On the top of this, you see a picture of the wet market from Wuhan, China. And this is a place where all kinds of meat or live animals are sold. And it is believed that the virus has jumped from many animals to the human body or human beings by transmission from one animal to another animal. It is believed that the bats is the biggest reservoir of the coronavirus. It can harbor about 160 viruses. And these viruses have jumped from that to another animal called pangolin. And from pangolin, it has come to human beings. That's how it is believed that Wuhan, or this wet market, is the epicenter of the entire epidemic or a pandemic of the COVID disease. This is the worldometer, which looks at the figure that Dr. Balla mentioned. Look at here, 2 million, more than 2 million confirmed cases across the globe. You see all over the world is well lit red, suggesting the prevalence of the disease is gone across the globe. And if we look at the number of deaths, it is more than 134,000 people have died. This is the figure in the morning at about 4:30. Now it must have gone up beyond that. And the number of people who have undergone the testing is about 3.2 million. So this is the number of people who have been tested for coronavirus. And this is the number of deaths, which is more than 134,000. Imagine the impact of the disease across the globe. Now, when you want a diagnosis of this disease, the classical symptoms and signs of COVID disease are sometimes highly atypical. It includes the respiratory symptoms commonly with a cough, usually dry, has fever, and dyspnea, and of course can get into viral pneumonia. And to make a diagnosis, it is based on the epidemiological history, clinical manifestation, various kinds of tests we'll go through, and of course the blood culture. But this is the publication from the NEJM, which came in the month of February, when they saw some new cases getting admitted in the month of December. And this is how it was seen that around 27th of December last year, few patients were getting admitted in Wuhan, and they presented with fever and pneumonia. These are 3 patients, a prototype. The first is 49 years old, second is 61-year-old male, and the third is 32-year-old male patients. And all the patients' clinical profiles available. Patient 1 and 3 recovered, but the patient 2 unfortunately died on 9th of January. If you get into further details, the first patient had again symptom of cough and fever and developed respiratory distress, and afterwards he was admitted in the hospital where pneumonia was diagnosed, but fortunately recovered and went home. And history of occupation showed that he was retailer in the seafood wholesale market. And the second patient again had cough. After 7 days, patient went into acute respiratory distress. He was ventilated, but unfortunately on 9th of January, he passed away. And he was also a frequent visitor to the seafood market of wholesale Wuhan. All of them suggesting that the original disease somewhere is in the wet market, probably in the Wuhan. So because this number of patients getting admitted somewhere in the December and January, on 31st December, the Chinese Center for Disease Control sent a rapid response team to Hubei provincial Wuhan city to identify the epidemiological and the etiological cause behind the disease. And it was Dr. Li Wenliang who for the first time was a whistleblower of the disease, who was actually professionally an ophthalmic surgeon. But then he sent on his cell phone to all his friends that a new virus is coming up, which presents like fever, cough, patient becomes breathless and has a very high mortality. For which he was reprimanded, and unfortunately he himself contracted a disease while examining a patient of glaucoma and eventually passed away on 7th of February. At the same time, his colleague called Ifen, she was also working in the same hospital in the Department of Emergency, and she identified these patients who came with fever, cough, breathlessness, and tried to investigate them but could not find the cause of the disease. And she tried to aspirate the bronchoaspal lavage and also lower respiratory tract secretions. And this is what she found on the electron microscope. When you use electron as a beam for the microscope instead of light, it is called an electron microscope. And it is also called as transmission electronscope when the speed of the electron is very fast. If you look at the frequency of electron, it is 100,000 less than the frequency of light. And therefore, the clarity of the picture is very good. It also says negative staining. What it means is the background is white and you can identify these viruses as the negative shadows. You can also see them here, the negative shadow viruses. And the arrows point out to these cilia in the respiratory tract. And therefore, this was identified and they felt this is very similar to what happened earlier in the year 2002, 2003 and 2012, 2013, which was again a type of a coronavirus. So therefore, it was believed that this could be a type similar to coronavirus. And those 41 patients were admitted in Jan 2020 at Wuhan, and out of which the men were 73%, majority of the men, 20% had history of diabetes, 15% had hypertension, and the cardiovascular disease was present in 15%. And the data was collected, analyzed prospectively by RT-PCR and a next generation sequencing. And therefore they found this kind of virus. If you look at the history, if these are the number of admissions, those 41 patients which I mentioned, the age group, a large of course number of patients were 25 to 49, but number of ICU admissions were less. But the elderly population, number of ICU admissions were equal compared to the admissions. If we look at history of the exposure to the Wuhan seafood market, you see by 27th or 24th of December and 27th December, 100% of these people had exposure to this particular seafood in the Wuhan market. And therefore, the epidemiological alert was raised on 30th of December, and this market was closed 2 days later for the public. It's very sad to say it is reopened again a few days ago. And not only is reopened, but it is reopened with a lot of incentives to both who buy and who sell various kinds of live animals. By the month of March, around 6 times, about 1,900 patients were collected, and these were admitted in various hospitals. And just to remind you, on 13th of March, WHO declared as a pandemic of the coronavirus infection. Symptoms and signs who were admitted in these patients. Fever was the most dominant symptom. Cough was about 76%, and it is predominantly a dry cough with little expectoration, both patient in the ICU and non-ICU. Headache was a not very important symptom. Some patients had GI manifestation of diarrhea, with large number of patients who became ill or especially critically ill, developed dyspnea, and these patients required intubation and ventilation. It's very interesting. There's about few percent of patients were asymptomatic. And what was the manifestation of asymptomatic individuals? Confusion, cognitive dysfunction, and anosmia. In fact, there is reports of few cases who did not have fever, but had these manifestations of anosmia. And a routine investigation of these patients also turned out positive. So these were the cases who infected other people who themselves did not have any symptoms. So these are the same that I mentioned earlier: fever, cough, headache, and this is manifest that we normally see. If we look at the timeline of these patients who came after the onset of illness, it really took 7 days for them to seek attention in the hospital. On the 8th day, just 1 day later, they became dyspneic. And next day, on 9th day, they developed acute respiratory distress syndrome, and they require intensive care manifestive management and also ventilation. If you see, about 39% of the patient passed away at the end of 16 days. So this is what the presentation, which is very dramatic and very explosive. The patient presents 7 days later, and by the end of 16 days, patient dead. If we look at the temperature, these are the temperature that was seen. The majority of the patient had a mild temperature. Very few had a little high temperature. If we look at the lab evaluation, leukopenia was quite obvious. It was also very well seen in patients with viral fever, which was seen in 25% of the patients. Lymphopenia, which is not really a hallmark of a viral infections, but these patients had lymphopenia. And if you see the picture on the right here, which I've shown you, the picture of the virus, which is lighted up with fluorescence imaging, we see here the arrow. These are lymphocytes. This is called CD146 lymphocytes, and all the virus particles have entered this particular CD lymphocyte, and that's how there's a lymphopenia in these patients. I want to remind you again that this is very similar to what happens in HIV infection. HIV infection also has a virus, but it attacks the CD4 cells, and after it attacks CD4 cells, it makes the nuclei multiply more number of the RNA virus of HIV. But here that does not happen. It only the lymphocytes die off. Therefore, the lymphocyte count is quite less in about 63% of patients. And what's important is the ratio of a neutrophil and lymphocyte count. It's more than 3.13 in people above age of 50 years. It is associated with severe illness. This is a very important observation here. About 38% of the patient had increased transamine levels. The LDH and serum ferritin were tissue reactive, fast tissue reactive were positive. Procalcitonin was normal in most of the patients, and few patients had increased prothrombin time, INR and D-dimer. Presence of a high D-dimer also are linked with a poor outcome. Interleukin-6 levels are higher in those patients who had a cytokine starve. Some of the patients also had a cardiovascular manifestations, and they had a high levels of high sensitivity troponin T. To identify the disease, gold standard is what is called nucleic acid detection technology. And this technology requires an expert person who can identify the specimen from the nasopharynx. It's very important that you should have a proper collection. If the collection is not proper, you might get a false negative report. The test is very valuable, but it has to be done properly. And to get the proper yield, you require a trained person to get this particular good yield of the test. And this test is called as a reverse transcriptase or real-time quantitative polymerase chain reaction, which identifies the RNA, which is of polymerase chain reaction is the most common and the effective and a straightforward method for detecting pathogenic viruses in the respiratory system. What we can now also do what is called as a pooled analysis, in which you take 5 patients sampled together and then send the sample of 5 patients for estimation of RT-PCR. If the test is negative, then all these families, all these 5 people, we can take 1 member of each family and they all 5 are negative. And therefore, you have almost screen like if you can take 3 members in each family, that means you almost checked 15 people at one test. So this can be cost effective and you can check more number of patients. In case the test becomes positive, you need to check each and every individual. There's also a rapid antibody test, a lot of confusion created by this test. This test tells you, what, as the name suggests, it means it gives you a report very early. We require just drop of a blood. It's a blood test as opposed to the previous test, which was the nasopharyngeal swab. This is the blood test, and the test is read in just 15 minutes. Here you have a patient who is symptomatic with something like influenza-like disease, and patient after 14 days, you can do the test, and the test comes positive. It's probably the patient has a probable cause of COVID-19. If the test is negative, if the clinical suspicion is strong, you need to do what is called RT-PCR, and comes positive and treat as a COVID disease. If it's negative, then again you need to follow up these patients very carefully to see, they repeat the test when the test comes positive. If the test is negative again, then if the PCR is also negative, then these patients are again observed and these patients are followed up over a period of time. That's how you can get the idea of the surveillance of the disease in a particular population. This test can be useful. The utility of this test for diagnostic purpose is doubtful, and therefore for the time being, it is still not approved by any organization to do for the purpose of diagnosis. US FDA has also approved only one company, from North Carolina, where the test can be done, but I don't know whether it's purpose of diagnosis or only for surveillance diseases. Radiology forms a very important investigation in these patients. If you look at the X-ray here, you can see on both the sides bilateral lesions, which is called the ground glass appearance. Classically, you see this ground glass appearance. The air shadows are dark normally, but here you see light shadows, ground glass appearance. And the same thing you see on a CT scan, which is usually 98% have a bilateral shadows. The problem with CT scan, once you use a CT scan machine, if the patient is positive, when the next patient goes for CT scan, the machine has to be prepared again, it has to be disinfected, so it becomes not a very cost effective. So therefore, chest X-ray on the day of admission or on the day when you see the patient for the first time, and if the X-ray is normal, you can repeat the X-ray after the third day. This is how you can identify various kinds of pneumonia based on the chest CT, the classical ground glass appearance, the classical feature of COVID-19. Other viral pneumonia, especially influenza A and B, do normally have interstitial inflammation with high attenuation and reticular pattern. And common pneumonias are usually lobar pneumonias with air bronchogram. So therefore, these are very easy to diagnose. Normally they are unilateral, but both these diseases can be bilateral. Sonography of lung has come up as a new modality of investigation in recent times. This is a publication which came on 16th of March 2020. A young doctor by name Joshua from California has been trained in doing this test. So the ultrasound, he says that the COVID-19 outbreaks, less stethoscopes and ultrasound. And these are various ways in which you can do this ultrasound test on the body, the anterior and posterior. And this is of course the shadow of the rib. You can add this is shadow of the pleura. You can identify the zone from air to the fluid and can give a good diagnosis. This could be a substitute for a CT scan, provided done by an expert person. So therefore, a lot of things are being thought about using this modality of test to make diagnosis of the COVID disease, especially the patient has pneumonias. So if you look at the clinical outcome of these patients, but if those are survivors and non-survivors admitted in the Wuhan hospital, we look at these patients, we look at the or the RNA particles in the nasopharynx. These patients continued to excrete, or the viral particle was seen even after discharge, suggesting that these patients could be an exposure for the fresh infection to other people who are not infected. So this shedding of the virus continued even the patient became all right in discharge and went home. In contradistinction to that, The patient who did not survive had a longer stay in the ICU and required a ventilation, which was invasive ventilation. And because of that longer stay and the higher inoculum, these patients did not do well. These are non-survivors. These are totally about 171 patients, amongst which these were survivors and these were non-survivors. Those patients who had history of pneumonias, the duration of disease told us about the outcome. The longer the stay in the intensive care, the worse was the outcome. The central line is the median line, and the line dotted above and below are the 95% confidence interval of this particular graphic picture. So therefore, the duration of the stay in the ICU in a patient who had pneumonia was actually a kind of a marker of the patient's survival. The longer the duration, the patient did not survive long. Coming to the clinical features of intrauterine vertical transmission of the COVID virus infection in the 9 women who were seen during the Chinese epidemic. And here, 9 pregnant women who underwent treatment and recovered and delivered a normal babies. And it is a good news that there was no vertical transmission of the disease. So therefore, this suggested there was no vertical transmission of disease in these patients. Moment you are diagnosed with the patient of COVID, what are the instructions, what are the things we have to do after having diagnosed? Of course, first is everyone wear a mask. The mask is very important and people must wear masks. The very important study is the Czechoslovakian study, where they made everyone wear mask. And you see the number of cases in Czechoslovakia are far less, again suggesting that this simple treatment was very effective. There are 2 kinds of masks available. These are called surgical masks, which are loose fitting, and tightly fitting are called respirators, or what is called N95 or N100 masks. And these masks are the one which can filter any particle which is greater than 0.3 micron in size, in diameter. So therefore, it can certainly filter many viruses, and therefore these are quite safe for the healthcare workers. So these are the good masks, but can be restricted only to people who work in the hospital, or the healthcare workers, or who are exposed to people suffering from a disease. There's another good idea of doing elbow bumps, that it also maintains the social distancing. And when you need to sneeze inside your arm, not in the palms, because palms will carry the virus and virus can continue spreading from one person to another. Communicating with the patients and the families and motivating healthcare team is very important. And the best message is to stay home, to break the chain of transmission and flatten the epidemic curve. What does this flattening of the curve means? I think yesterday it was discussed by preventive social medicine doctor, where he said that if the outbreak suddenly occurs in the society or in the community, it is difficult to contain because of the limitation of the hospital care for these patients to be treated. If we can limit this curve and flatten it, so we can offer a better kind of treatment. And I'm proud to say there's a good example from India, and this is called the Bhilwara pattern or Bhilwara case, which is a small city of a 5 million population in the state of Rajasthan. And here the first one doctor who was an anesthetist got infected with this virus. He immediately reported this matter to the health secretary, and health secretary took immediate action, cordoned the city, and they called for lockdown 2 days prior to the lockdown of the entire country. They hired about 25 hotels and 5 nursing homes where they kept all these patients and did vigorous testing. And the good news is, since last 2 weeks, there are no new cases coming from Bhilwara. It's very interesting that this is the place which has no kind of access to any metropolis cities. And 45 cases seen for the first time in this particular city was classically eye-opening, whether it's a community spread, whether how the infection got, how we got was not a problem, but how we managed was important. And we have managed so well today And this is called Bilvara pattern, which is the most ideal pattern to flatten the curve. Washing hands is very important. You need to use soap because soap can actually take away the envelope of the virus, and therefore the virus cannot survive. To remind you, viruses are not cellular organisms. They are not living organisms. They don't have nucleus. They don't have organelles. They don't have mitochondria. They use the human machinery to multiply themselves. So therefore, using soap, once you take away the coat, these viruses cannot propagate in the body. Therefore, using with soap at least for 20 seconds is very important. You need to use personal protective equipment, especially if you're dealing with acute cases or patient, you're working in the hospital where the contact is trying to be very high. It's important that 80% of the cases are mild cases, so they don't do well. About the 20% of the patients are one who require hospitalization. Of the 20%, 5% is the fatality. So therefore, we need to take care of those 20% of the patients who require a correct treatment so that they can also survive the disease. The classification of the disease is based on the severity. There's a clinical classification where it says a mild disease, where the patient has very few symptoms of fever and cough. He's not breathless or she's not breathless. There are no comorbid conditions, and this patient can manage at home with just supportive care and giving them adequate hydration so they don't get dehydrated. The second one is the severe variety of care, which is moderately severe, where these patients are dyspneic, they're hypoxemic, they require oxygen therapy, they require a CT scan or X-ray to identify they got a pneumonia. And many drugs have been tried, like oseltamivir is tried, azithromycin. This is in China, but it's not effective. Azithromycin, hydroxychloroquine, which I'll discuss a little later, lopinavir. I'll discuss all these later. These are the drugs which are given to these patients. And the critically ill patient required desperate treatment to overcome the crisis. They have what is called as a cytokine storm, where a large number of interleukin-6 is responsible for the release of all the cytokines, which are the small proteins produced by the body. And they bring about a lot of symptoms of breathlessness, and they require severe hypoxia, they require ventilation. And tocilizumab is one drug which is interleukin-6 antagonist, which can be tried in this dose of 400 milligrams intravenously or 8 milligram per kilogram body weight. And in convalescent plasma can also be tried in patients who are acutely ill. These are all the anecdotal cases where the results are supposed to be good. If you get plasma of one patient who's recovered from a disease, you can treat 4 patients of severe COVID disease. These are the stages of COVID disease, which is called the early infection phase. Then you have a pulmonary phase, which is 2A and 2B. And then you have a late, which is called hyperinflammation phase. It needless to say that in the stage 1, patients have mild symptoms. Stage 2, the patient becomes breathless and he has abnormal chest imaging such signs, and transamine is high. And patients critically ill are called ARDS patients, and they have elevated inflammatory markers, and these patients are critically ill. So this inflammatory response of the body is the one which is for the mortality of these patients. Now, drugs available for us, we have hydroxychloroquine, which has been used for these patients, is available. And this drug works by multiple mechanisms. First thing, it prevents glycosylation of the receptors, which is called ACE2 receptor. Therefore, the virus has no entry into the lysosomes or endosomes. Lysosome pH is elevated by chloroquine, hydroxychloroquine. So therefore, these RNA particles can't survive and can't multiply. And also, this particular drug can allow the zinc particle to get in. Zinc is actually a polar atom, so it doesn't have entry into the cell. But chloroquine facilitates the entry of a zinc into the cell, and the zinc, after it enters the cell, inhibits RNA-dependent RNA polymerase. So therefore, the RNA multiplication in the ribosome doesn't take place. That's how the chloroquine has a multiple proposed mechanism of action to treat. It is supposed to treat both the viral phase of multiplication or replication, and also treats the hyperinflammatory phase in both situations. What is interesting here between chloroquine and hydroxychloroquine, if you see here, these are what is called the Vero cell studies. Vero cells are a cell which are obtained from a green monkey. From a green monkey, you take the kidney. From the kidney, you take the epithelial cells. Reason why I pick up the Vero monkey cells, because these are the monkeys who do not produce antibodies to the virus, but they have receptors for these antibodies. So therefore, these are the cells which are used to study the antiviral properties. If we look at the chloroquine, the 48 hours EC50, that is effective concentration, is quite high. It's 5.47 compared to hydroxychloroquine. So hydroxychloroquine that way is safer, less toxic, and less amount of doses required to take care of these patients. This is the French study which looked at a small number of patients of 36 or 34, and they were about 12 years of age. These are the control people. These are the hydroxychloroquine. This is a combination of azithromycin with hydroxychloroquine. At the end of 5 days, you see the virus has almost disappeared. And that has prompted the president of USA, Donald Trump, to request for hydroxychloroquine from India, which our Prime Minister was very happy to give him that. The study was done by Professor Diglia Roloff, and it was said that this study sample is too small. He went ahead and did another 1,000 patients of COVID-19 and gave at least 3 days of hydroxychloroquine azithromycin combination and followed up for 9 days and showed almost similar results. There's one more Chinese study which looked at 62 patients of the COVID infection, and the inclusion criteria include lab confirmed on the RT-PCR more than 18 years of age, and they just had pneumonias with, they have SaO2 SpO2 ratio which is more than 93%, and exclusion criteria, all critically ill patients, retinopathy, retinal damage, conduction blocks, arrhythmias were all excluded, and 31 patients received hydroxychloroquine, and in this the mean age was 44, and there was a 47% are men and 53% women. And what did you see? And you see there's a good amount of improvement in patients who received hydroxychloroquine here, and also had the exacerbation was quite less when you use hydroxychloroquine. Basically, hydroxychloroquine is immunomodulator. The ICMR in India gave a prophylaxis schedule for the patients who are healthcare workers who are involved in the care of suspected confirmed case of COVID-19. It's at 400 milligram twice a day for day 1, followed by 400 milligram per week for 7 days, and asymptomatic household contacts of a lab confirmed cases, 400 milligram once a day, but twice a day for one first day, and followed by 400 milligram per week for 3 weeks was what was suggested. And of course, the exclusion was those not recommended for children below 15 years of age, and those who have hypersensitive to drugs were not included. This is a very interesting slide, though it's an old one, but I want to explain the important mechanism and how the prophylaxis, whether it's useful or otherwise, is studied by this particular graph. You see these are the dotted lines which looks at hydroxychloroquine, and the straight lines are the chloroquine. These are the treatment was given every weekly basis, that 200 hours, 400 hours, means once a week the therapy was given. To have the drug effective, you need to have the concentration of the drug in the plasma to a tune of 500 microgram per liter or a 5 microgram per ml. Either of the way, that has to be given. Now, when you give the dose which I mentioned earlier, you can hardly reach that level. You require at least 632 milligram to get this much level. So you require to have at least 600 milligram minimum to get this particular dose. And therefore, what is interesting is that the dose can peak, but it immediately falls down. So it does not have that kind of a maintenance for 1 week. This is in contradistinction with malaria. When in malaria, the drug gets concentrated in the RBCs, and the RBCs have the malarial parasites. So therefore, it might work well for patients with malaria, but not for patients of COVID infection. Remdesivir is another drug, which is antiviral drugs, which is called a compassionate use of a drug. And what is shown here is for prophylaxis, the drug is of no use. It's only for treatment therapy. It has to be given intravenously, 100 milligrams every 24 hours. It's contraindicated in patients who have low GFR and increases transamine levels. And it's effective in about 50% of patients. In contradistinction, if you use chloroquine, It's effective in about 80% of patients. Oral preparation is also probably effective in prophylaxis as well. This is a trial of lopinavir-ritonavir combination in a hospitalized patient with severe infection. These are the 200 patients in the dose of 400 to 100 milligrams of lopinavir-ritonavir. This is a combination used in Ebola infection also. This was tried here, and here what you see at the end of 28 days, the graph separate is there, but not very significant. So this combination did not accelerate clinical improvement, reduce mortality, or diminish throat-wide RNA. This is the Chinese study. So Chinese study did not show much improvement in these patients. Ivermectin is a drug which is basically used for patients of filariasis, was also approved drug. Ivermectin inhibits the replication of SARS-CoV virus in vitro. This is an Australian study which looked at the use of ivermectin in the patients of COVID-19. And what did you see here? At the end of 3 days, you can see the viral replications come down quite significantly. Even in the supernant fluid of the blood, the virus particles have gone down significantly. But this is the 99% or 93% effectiveness of a drug, so it's very efficacious, but this is in vitro study. Trial needs to be done, conducted in human. The results from this in vitro study should not guide the clinical practice. And how it helps. What is important is the RNA has to travel to meet the nucleus and the DNA in the cell. And for that it has to cross the nuclear membrane. And at the nuclear membrane, there is a prevention for this particular RNA to get into the nucleus. That's why it prevents the entry of the RNA into the nucleus. That's how the drug works at that point, at that stage. This brief report raises the possibility that ivermectin could be used for antiviral to limit the COVID infection, but we require more data to use it. Anti-diabetic drug DPP-4 and the COVID infection, there is a data that the DPP-4 expression or DPP-4 receptor is used by the COVID virus to have access to the pulmonary pneumocyte type 2. And if you give DPP-4 inhibitor, probably it will also work in these patients to reduce viral load. This is still preliminary data. We need to have more proof to this. So therefore, to summarize whatever drugs I mentioned so far, they work either at the entry, or they work at the replication levels, or they work at the level of the storm, or they work for the prevention of the replication of RNA polymerase enzyme. So at multiple sites, the drugs work on this and therefore can contain the infection. Sometimes the question is asked, are the patients with hypertension and diabetes are more increased for COVID infection? Because we know that the COVID virus, since this virus has access to the cell through what is called ACE2 receptors. And patients who have been taking ACE inhibitors or ARBs for treating either diabetes or hypertension have overexpression of ACE2. So consequently, the increased expression of ACE2 would facilitate the infection of this particular COVID virus more predominantly. But of course, that is not seen in most of the patients because the American Heart Association has said that patients should continue medication. And the European Society of Cardiology also said that the physician should not stop the medicine, but should continue unless there is a contraindication for some other reason. So therefore, these drugs can be continued. A very important aspect was also studied in this Wuhan epidemic of coronavirus. That was the fatal outcome in patients who had existing cardiovascular disease. And you had 187 patients with confirmed COVID infection, and some of them had established cardiovascular disease. Now, if you look at the troponin T and NT-proBNP, the high levels of troponin T and proBNP was important cause for increased mortality. In normal levels, the patient were comfortable and be discharged. So it raises the possibility whether this virus has damaging effect on the myocardium or a cardiac injury, therefore resulting into increased mortality in these patients. We know diabetics are more susceptible for infection. What about diabetes and infection? Tomorrow, The speaker is going to elaborate discuss this, but just to touch this point, the risk of infections like influenza and pneumonia are very common in diabetes. Therefore, at the end of 2 years, we recommend them to give pneumococcal vaccine and influenza vaccination. So diabetes associated with increased risk of a severity of infection, especially respiratory virus, especially the sugars are about 200, because beyond 200 sugar, the complement system is least effective and there's a glycosylation of more of these antibodies. So therefore, they are not effective in patients with diabetes. Now we have a history in 2009 H1N1 infection, the SARS in 2002 and MERS in 2012, where diabetes was an important risk factor for mortality. Of course, currently we have limited data now. We still have to work on it. And therefore, as of now, a good control diabetes should not be a problem, but a impaired or poor control diabetes has possible risk of getting the infection. Talking about again diabetes, patterns emerge. Dr. Ann Peters was actually from Keck School of Medicine from California. She says, she's authority on diabetes. She says, I'm seeing what we expect, that most patients, even those at high risk, can be treated if the disease is recognized early, very important, recognized early, and treatment is available, like ventilator, everything that can be managed. So she says that the patient SGLT inhibitor to stop the drug, the first set of symptoms of fever, to reduce the risk of diabetic ketoacidosis. Patients on sulfonylureas or insulin need to lower the dose or sometimes stop it, and you monitor the sugar very often. And many of the patients who recover from COVID infection still continue to have anorexia. So those patients, you need to stop the GLP receptor agonist at least for a week or two. Maybe you can continue later. But most important thing she says about the COVID infection diabetes, she says that the patients with diabetes and COVID infection, the risk of decay is quite high because many of them can't keep the fluids down. So they need to get hospitalized, and patients should not wait unnecessarily. So delay in seeking admission in the hospital might mean a severe infection to these patients. So therefore, time, it says stitch in time saves 9, so you should be much in time, ahead of time. This is the fatality rate among diabetic patients and all other group of patients. 44,000 patients seen in the COVID infection totally. 2.3% is the rate of fatality. Below 9 is almost 0, 70 to 78%. Above 80 years is 14.8%. Patient diabetes is 7.3%. So again, diabetes has a little more risk, but much less compared to people above 80 years and those with cardiovascular disease. What about vaccine? Is there any role of vaccine? So it is very interesting to see that John Cohen was actually a man who worked in maximum HIV virus and in HIV vaccination. He is a scientist of par excellence in USA. He's saying that the fastest development to make vaccine was in the COVID disease. Look at 8th of January, they identified the virus. And by 10th of Jan, the work started. This is the fastest work one can think of in any production of a vaccine. It took much more time in other cases. But for example, it took 6 months in case of influenza. And Jennifer Heller received the first administration of mRNA 1273 vaccine made by Moderna USA from Pennsylvania. And we need to wait at least 6 months more till the end of December to get a truly vaccine. This is a CureVac from Germany. We're also very active in making vaccination. There's a lot of news and thought about the BCG vaccination, whether it can cure COVID disease or contain the disease. India was a country which started mass vaccination for tuberculosis in 1948. If we look at Japan, Japan also started vaccination universally in 1947, 1 year ahead of us. And look at the deaths in Japan now is 0.28, far less. Look at Brazil, they also started vaccination in 1920, and their rate is also far less. So looking at the history of Brazil, Japan, and India, the number of patients having infection and death, the mortality is far less. So this all prompted people to suspect whether this vaccine gives any protection or at any point in vaccinating now again to get the immunity. There's a lady called Monica Gulati who also says that this may be effective. And we have Scientific Society of Research, Dr. Mishra, who also says that there is some more data is necessary. It is believed that when you give BCG vaccination, it produces what is called as interleukin beta. The interleukin beta in turn stimulates patients' mast cells to make more macrophages and also stimulates more production of the killer cells. In other words, this interleukin beta potentiates the herd immunity or the innate immunity. Therefore, it improves the patient's immunity. British Medical Journal in 2016 published data in which the BCG was given, 2016, and the idea was to see what benefit you get. This was to see whether there any benefit you get in influenza. And what was interesting was when they gave this vaccination in these patients in 2016, they found yellow fever incidence was going down. So therefore, there are a lot of things which are possible. At the moment, it's conjectural. We don't have the exact evidence as to what it is. But all these data that I'm showing you, steering at one point, and there could be some meaning behind the use of BCG vaccination. The only exception perhaps is Iran, where the BCG vaccine is also universally given, but they have very high fatality rate. But this increased fatality in Iran is in the elderly population. So we don't know whether it is the elderly population which is showing the increased rate of fatality or whether BCG is not effective in these patients. So with that, I think I've come to my last slide. Thank you very much for the patient listening.
Thank you, sir, for your elaborative talk on this topic. I think the take-home messages from your talk, if I have to summarize, is that treatment is based on the severity of the illness. That is one. Number two is there is no evidence of intrauterine infection transmission so far which has come over. There are certain criteria which all of us have to adopt if we want to decrease the spread of coronavirus pandemic. That is, stay home to break the chain, transmission chain. That is utmost important. Practice social distancing as much as we can. That's why the second lockdown has been announced by our Honorable Prime Minister. And now in India, it is going to be there till 3rd of May. Wear mask whenever indicated and wherever it is indicated. Some of our, it has become compulsory now to wear the mask in Delhi, in Maharashtra. So that is the criteria. Test, isolate, quarantine, and contact tracing. That is the another one of the major criteria. Do not panic, because at such type of pandemic situation, there are so many IEC messages which are going on, which creates a lot of panic, lot of WhatsApp messages. So we don't have to create the panic, but face the real situation. On the other hand, if you see 80% of your cases are mild cases. It is not that all the cases are severe cases. You don't need ICUs and ventilator for all the cases. So majority of the cases are mild cases. Stick to your doctor's advice on lifestyle management and medicine and be at the goals. PPE for the healthcare workers, it is necessary. Wash hands thoroughly with soap and water. These are some key fundas which all of us should adopt, and it is a globally accepted things that social distancing, when South Korea has adopted so early. South Korea has adopted all these steps like isolation, contact tracing, quarantine. They have become a shining example to curtail this particular coronavirus disease. I'm sure that the majority of we have one thing I want to share with you is we have 22 countries healthcare professional representation today in this seminar. So it is all from all across the globe. I'm sure there may be multiple questions and queries they must be having. I'm handing over to you, sir, for the various queries they are having, sir.
Thank you, Dr. Balla, for your synopsis of the entire talk, and you summarized it very well. And it's, as you said very aptly, that it is very important that 80% of the patients do not require any major treatment. That is absolutely true. It's only 20% of the population, amongst which the 15% do well, only 5% are the ones who have increased mortality. So there are plenty of questions are there. We'll start answering them. The first is oral corticosteroid indicated in mild to moderate cases since IV steroids are used in critical severe illnesses? To be very honest with you, there is no role of steroids in any of these diseases. In fact, the use of steroid was associated with the prolonged infection. The virus tends to stick inside for longer duration of time if the steroid was used. Only in situations where there is an exacerbation of asthma, suppose patient has got COPD and the COPD becomes bad, that is the only indication we use steroids. Steroids have no role to play either mild, moderate or severe infections of COVID. Very important. The use of steroid is associated with prolonging of infection. Patient continues to shed the virus for longer period of time. Please do not use steroids. In China, it was reported that some treatment centers added a very high dose of vitamin C to treatment. Is there any evidence for the efficacy of vitamin C? Obviously no, because vitamin C is what? It's basically antioxidant. And when you have a disease producing by virus, you need to treat the antiviral drug as a treatment of choice. That whenever you talk of treatment, when you think of Koch's postulate, which is taught to us in the medical school, somebody gets an infection by an agent. The idea of a doctor is to identify the infection and treat with appropriate drug. Vitamin C has no role to play at all. I think it's all empirical treatment. A lot of people give this empirical treatment. I must tell you one more thing, which is very interesting. When the investigation was done for HIV patient to begin with initially, there was one paper which looked at the use of chloroquine in the HIV infection. You'll be surprised when I say this, chloroquine in HIV patient. And what was the result? Very good result showing the replication of virus becoming quite less with the use of chloroquine. These are all few stray cases which you see. They do not mean a medical science. Medical science requires evidence, and vitamin C is not evidence-based treatment. The only place where you can use vitamin C is patients with scurvy. The index disease of a deficiency of vitamin C is the only place where you use vitamin C, otherwise it is not indicated anywhere. Role of steroid again in a severe acute respiratory distress. Now here's again, I told you earlier, that the patient has existing chronic obstructive disease and then becomes breathless or becomes bad. In that situation, you can identify that this patient has, you can use the patient, these patients steroid therapy. Otherwise, there is no indication to use steroid at all. One way to identify whether the patient has the exacerbation of chronic obstructive airway disease or this breathlessness is purely because of COVID infection is to check the patient's PaO2 and SpO2. There is always a disparity between PaO2 and SpO2. The PaO2 is a partial pressure of oxygen, which is usually normal, but the SpO2 goes down in patients of COVID infection. And why this should happen? The reason why this happens is that in a hemoglobin, we have a heme as a particle in beta chain. The heme is stripped off from the hemoglobin by this virus. And therefore, each atom of the hemoglobin carries 4 molecules of oxygen. So the oxygen carrying capacity of hemoglobin is quite good. When you strip the heme off the hemoglobin, the oxygen carrying capacity goes down. And therefore, the shift of the curve is to the right. It's called shift to the right. And that's a time when you see the patient, his PaO2 is normal, but SpO2 is low. But of course, when the patient gets an advanced disease, a large amount of fluid in the alveoli, then of course both of them go down. But in contradiction to that, patient of asthma may have both low. This is one way you may differentiate one from the other. But of course, this is the early stage of the disease. Subsequently, I think this distinction is not possible later. So role of steroid, I said about that. What's the place for a drug prophylaxis or an early treatment in COVID? I mentioned that in India, we have so far, the prophylaxis is given only patients who are in a contact of an infection patient, lab-proven infection, where we give 400 milligram twice a day on the day 1, followed by 400 milligram per week for 3 weeks. And for a medical care worker or a doctor, you give 400 BID for the first day, and subsequently you give 400 per week for 7 weeks. There's also a good study on this subsequently. This was published somewhere in the month of March, 21st March. On 31st of March, there was no publication that has come from southern part of India. And it looked at the blood levels of these patients when the therapy was given like this. It was shown that when you give 400 milligram twice a day to a patient, the toxicity level also goes very high. So there's some thought by these doctors who looked into the steady state of drug after giving drug therapy. Is they say that you lower the scale, instead of giving 400 BID, you give 200 BID and then maintain 400 per milligram per 7 weeks, or 200 BD again, not give one single dose, but give 200 twice a day. This is just one study which looked at a very small number of patients, but also makes a sense because they studied the drug level and then they came to this conclusion. But this is not what the ICMR recommends. Steroid, they said, what's the role place of prophylaxis I mentioned? How true is the BCG vaccination protective against SARS and COVID-2? As I said, that when you give this kind of vaccination, BCG vaccination, it is supposed to boost up your what is called an innate immunity. And what is innate immunity? Is the immunity with which you're born. When you're born, you are not exposed to any of these infections, either virus or the bacteria. So therefore, your body is very sterile. The moment you get with some infection, the body has its own innate immunity to deal with this kind of infection before it learns about the production of antibodies inside the body. And you will have the mast cells, which ultimately become macrophage, and the killer cells. These are the cells, these are important, which maintain the immunity when you're not exposed to any infection. Now, COVID-19 is a new infection. So body is not used to this infection. So if a body has no immunity. But for those who have the innate immunity or a herd immunity, what's called as, they can tackle the infection. Now it is very convincingly proven that the BCG vaccination increases the interleukin beta. This stimulates the killer cells and also the mast cells to produce more macrophage. The mast cells, when they come out of the blood vessel, they become macrophage. And the macrophage is, macro means big, phage means to eat. It actually eats up these viruses and bacteria, digests it inside the nucleus, and takes a small piece and puts it out on the surface of the cell, and that is called the antigen presenting cell. It's called APC, antigen presenting cell. So this is how the body then develops immunity. Then the T cells identify this, and then they give the signal to the B cells, and B cells produce antibodies. That's how you get immunity against infection. That takes time. Before that occurs, this innate body helps. So BCG is supposed to improve this innate body immunity. And as I told you in the BMG publication of 2016, it has shown to prevent yellow virus, though there is a specific vaccine for yellow virus also. But still, there is a proof of that. Then is the Hidayat sir talking, congratulations for this fantastic presentation. I would like to know why massive testing is not recommended in all suspects or contacts. Wouldn't we have more advantage with this strategy? Yes, I think you're absolutely right. You hit the nail on the head. That's a correct thing to do. Actually, to contain the infection, quarantine is the one which is more important. Isolation, quarantine, and more testing and more testing. For testing, the gold standard, of course, is the RT-PCR. But the RT-PCR is not easily available. It's quite expensive test. But now we have the pooled analysis where you can test 5 people at one time. That can be done to identify more and more testing. The more you test, you come to know what is the spread of the virus. And the next is you calculate the doubling time. So the doubling time is 2 or less than 2. that means the virus's number of patients multiply very rapidly, then you have a propagation of virus in the community. So the doubling time is 7 or 8 days. Now in India it is 7 days. So that means we have contained the multiplication of virus very significantly. How many more questions I take? There are many more questions. Should I continue, sir?
So there are like, yeah.
Many more questions. Till what time I can continue? You can tell me, I can go on.
Another 10 minutes so we can.
Okay. Okay.
Yeah.
Mainit Kaur, I don't know whether I'm pronouncing the name correctly. I'm sorry if I made a mistake in pronouncing. Vaccines for COVID-19 is produced in China. Is it real, sir? No, it can't be. You take a lot of time to produce vaccine. Vaccine production is not easy. You need to study this in a healthy population. And you need to study younger population. If somebody gets a reaction, it's going to be a problem. Minimum period to make a vaccine is about 18 months, minimum. You can't do before that. Even if you put many people on work, it's not possible. But it is said for COVID infection, we expect from WHO the answer by end of December. So it's not possible. If they have, I don't know, everything that comes from China, we should take a pinch of salt. What level of PPE is needed for a primary care physician? Of course, PPE is only when those you are dealing with ill patients or positive patients where you have to protect yourself against getting infected. So therefore, PPE is important for those who are exposed to high-risk patients. Otherwise, for routine patients, if you're not practicing acute care medicine, you're not practicing infectious medicine, you may not require PPE. Therefore, for primary care, dealing with patients who have the infections, yes, you need this. What is the importance of nutrition on management of COVID-19? Any special diet required? Very good question. I think off the beat question. Yes, there are a lot of people who discuss about this. In fact, Nestle had a webcast on this of the diet management in the patients of COVID infection. What we should remember is that the COVID infection is a disease which is devastating. You need to have a good nutrition, especially a good amount of protein, because we need to have a good antibody production, which is of course a protein requirement. And you must have the immune system intact by good nutrition. I feel good nutrition does not mean that you must take only protein, but a balanced diet is fairly good enough. There is nothing a specific diet, a diet that can prevent an infection. It is not, there's nothing like that. But a balanced diet, good nutrition with all vitamins and minerals, what you need. I think that's what I feel, Linda. Nothing more than that. From PHFI, the question is, side effect of chloroquine is retinopathy. How many incidents and can recovery or not? Is it dose dependent? Yes, it is dose dependent. Now, there's a study done where they looked at multiple doses of chloroquine and looking at the concentration in various bodies. The highest concentration of chloroquine comes in the pigment layer of retina. It has affinity, it goes and fits there. And what it causes the color blindness, especially of red color. And many times we say this is a patient of chloroquine retinopathy is a bullseye. You know, bulls also, they bull fight, and that time they show the red flag to the bull. The bull is colorblind. Bull can't see anything. But the point is that these people have a slight deficiency of color blindness of the red color. The treatment is, of course, I mean, it is dose dependent. The higher the dose, the more common. Prophylaxis normally does not cause, short-term therapy does not cause. Between chloroquine and hydroxychloroquine is slightly better compared to chloroquine in terms of toxicity, but both have the similar risk. Yearly checkup of eyes is important, and the patient having any difference in acuity vision, the drug has to be stopped. Usually it is irreversible because it causes a defect in the pigment layer of the retina. There are 10 layers of retina. So the pigment layer gets affected, and that's how these patients have this kind of symptoms. It's very important to be watchful, careful, and be vigilant. The pharmacovigilance is very important. You have to be vigilant and therefore be careful. Azithromycin is an antibiotic which was recommended because this French study which looked at the combination of azithromycin and chloroquine, hydroxychloroquine in treatment is just a broad spectrum antibiotic, predominantly effective on the gram-positive organisms, probably has extension on the virus as well. The advantage of azithromycin is it has a concentration in the white blood cells in the lymphocytes longer time. So it stays longer into the white tissue. I don't know whether that has any effect or anything to say about the antiviral properties. Well, it is anybody's wild guess. Has been used. I don't know whether there's any scientific rationale behind using this. Personally, I feel there's no scientific rationale. How about HIV and COVID-19? Oh, good question. HIV is also RNA virus and COVID is also RNA virus. Both of them attack the lymphocytes. I showed in one of my slides that CD47 is a docking protein for COVID-19 and CD4 is a docking protein for HIV. And therefore, we try all HIV drug for this COVID infection because the virus is quite similar. Both are RNA viruses. The problem with HIV is that the HIV, once it gets into the CD4 cell, it starts replicating and produces daughter cells by the lymphocytes, starts producing HIV infection, CD4 counts start going down. In patients of COVID, it gets into the cell, all right, but doesn't multiply. It only keeps on getting accumulating in the cells. Eventually, the cell becomes dysfunctional, but doesn't replicate into the cell. So therefore, there is no multiplication of virus inside the cell. So that's the only difference between HIV and COVID-19. That's why we apply the treatment given to HIV also for COVID, hoping that it will work for HIV, it should work for this disease as well. All these are all conjectural, they're all hypothetical. We have to offer something to the patient by way of treatment. And therefore, this is how the science develops. Isn't all the discoveries are by accidents. Penicillin was discovered by Fleming, who never thought he's going to discover penicillin, but it just come by accident. So therefore, when you try this kind of combination, you hit upon some of these accidentally, some new medication treatment. Ventilator is effective in ICU patients? Oh yes. Ventilation is basically what? Ventilation is actually driving the air in the alveoli under the pressure. What happens in these patients is a lot of fluid collection into the alveolus. And the fluid is collected because of the increased angiotensin II. And that angiotensin II is because of the ACE inhibition. As soon as the ACE is occupied by the virus, the counter-regulatory effect is increased levels of angiotensin II. When angiotensin II is 1,000 times strong vasoconstrictor compared to epinephrine or epinephrine, and that produces severe hypoxia in the tissues. And the hypoxia produces clotting in the capillaries in the tissue. That's why it produces what is called increased prothrombin time, D-dimer being high in these patients, and therefore there's a lot of fluid which exudates from the capillaries into alveolus. And therefore the gas exchange becomes defective. If gas occurs, the blood vessels are blocked by these microthrombi. So there is a perfusion-diffusion defect in these patients. And to some extent, by using ventilator, you drive the oxygen under the pressure. And by doing that, you allow the oxygen to reach various tissues in the body. That was a good question. Kimyo. Hajra Ismail, we know that SARS-CoV-2 binds to angiotensin converting enzyme 2 receptors. So is it possible that losartan might block these receptors and may prevent virus from infecting these cells? No. What happens is losartan doesn't block ACE2. There are two pathways. It's called ACE1 pathway and ACE2 pathway. Let me make it clear. What happens is that when you give losartan or ACE inhibitor, it inhibits the enzyme, angiotensin converting enzyme, and therefore the ACE1 is inhibited, and therefore the constriction action of epinephrine or norepinephrine is also reduced because you're reducing the ACE1. And contradistinct that ACE2 level is elevated. ACE2 pathway is a vasodilator pathway. It brings about vasodilatation. So it's a different pathway. But when ACE2 is the source of entry Whenever you give ACE inhibitors or ARBs, ACE2 is overexpressed in these patients. There's overexpression because you suppress something, the other gets expressed. So when you suppress ACE1, ACE2 gets overexpressed. ACE2 is vasodilatory. And when you have the virus having access to the tissue by using ACE pathway, ACE2 pathway, so because there's high levels of ACE2, this virus can get into the tissue. That is your problem. So when you give these drugs, you indirectly increase ACE2, indirectly increase the virus entering into the cell at a much higher pace, at a much higher rate. But in practice, it has not been shown. So therefore, we need not stop these drugs. It is good for discussion as a hypothesis, but it is not true so far as the clinical cases are concerned. The nature is very kind to us, so it does not make too many problems for us. You may continue these drugs unless there is a dehydration. If there's a dehydration, then you should stop this drug. Thanks for the informative lecture. It's using hydroxychloroquine in prophylaxis in India. Yes, we have been under the ICMR guidelines. We have been directed to use the recommendation of hydroxychloroquine in patients who have a high-risk contact. But personally, I have my own personal feelings that it will not be that effective, but it's well, something is to offer. Yes, we have been directed by ICMR to use for prophylaxis. For healthcare workers, when is the best time to start HCQ prophylaxis? I think day one. Day one, because you're going to get contact anyway. The incubation period for the virus is 2 to 14 days. So 2 days is as short as that, and 14 days is a long time. So therefore, day one, when you are going for a practice, the day one, that is the first day you take 2 tablets, and then for next 7 weeks, 1 tablet per week. The next question, Dr. Mozardu, I'm sorry if I'm making a wrong pronunciation, please correct me. Can exposed patients can have lifelong immunity for COVID-19? How many percent of patients can have reinfection? Good. So this is a good question. See, the point is that once you get infected, the body develops immunity. So 80% of the patients I told you will develop immunity. So they get a lifelong immunity. Now it is believed that this COVID infection is likely to come every year. It will be going to be seasonal, like common cold. Common cold is also coronavirus. Same virus it is. But this has undergone mutation. So therefore, until such time the virus undergoes mutation, or the S protein undergoes mutation, S stands for spike. Spike protein undergoes mutation. In that point of time, the immunity will go off. Otherwise, the immunity will be lifelong because the T cells have a life of 25 years. 25 years will maintain the memory of infection of this particular virus. So therefore, it's going to have a lifelong immunity, almost. The next question is, what do you think about using ribavirin? Is it available in India? No, it's not available. It's a good drug. Was used again in certain viral infections. There is some data on that also, ribavirin also. It has been tried, but we have limited data. I don't have any experience of that, but it's a drug which is worth trying. It is a classically antiviral drug. Yes, there are some hopes, but there are no trials as of now. Augustine, what's your recommendation on diabetes come COVID-19? Should we stop all OHs, put them on insulin? And if insulin long acting, yes. I think any critically ill patients, it's better to stop oral drugs. It's a wise thing to do. And if the patient is not eating, so oral drugs can create havoc, can produce hypoglycemia. It's wise to use insulin. Now, what insulin you use depends upon how much patient is taking food. When the patient is a mild to moderate disease, taking his feeds all right, then you can use the short-acting insulin pre-meals and a basal insulin bedtime, because basal insulin is very important. It prevents ketoacidosis. The function of basal insulin is to prevent lipolysis and ketoacidosis. Therefore, you have to use basal insulin bedtime and a short-acting insulin prior to meal. That's the best way to use. It is best to stop the oral drugs, because the oral drugs, especially the SGLT2 inhibitors, which are known to produce the diabetic ketoacidosis, play safe to use injectable. I agree with you, Augustine. You can use injectable insulin. I think those with poor glycemic control can be switched to insulin. if the risk of COVID-19, but not those well controlled. You can also treat the patient otherwise comfortable eating well. Mild diseases, we leave them alone. Just quarantine them. Quarantine doesn't mean they stop their food. Give them food, but keep them away from other people. That's a quarantine, isn't it? In the lighter vein, some people ask me, what is quarantine? Is people quarrel at home. So it's a quarreling at home is called quarrel time. So that is not the correct meaning, but if the people are very comfortable and they have no symptoms, they can be left alone. Is there any racial differences in the clinical features of the response to treatment? Yes, this is what is called the pharmacogenomics. Why racial difference? Within the same community, you can have differences in the response to therapy. There can be 4 responses to a you can get 100% response, they're called responders. You get partial response, they're called partial responders. No response, called non-responders. And some people get adverse reaction. It is called the adverse reaction group. So these are 4 possibilities for any drug that you give to any patient, irrespective of the caste, creed, race, age, and sex. This is possible. And this is known as the pharmacogenomics. Your genes really control which drug is good for you, which is not good drug for you. But if you're talking in terms of COVID infections, we don't have much drugs to offer. And the drugs that we are using, for example, antibiotics and chloroquine, probably it is not much difference, except in African countries where there are a lot of G6P deficiency, where one has to be careful about using this particular molecule in presence of G6P deficiency. They also have sickle cell disease. That will be careful. The ACE inhibitors are drugs which are resistant in patients of African origin. So there are some few of the drugs which do not respond in certain races. But even in a given community, there can be different kind of people based on genetic background. And there's an entire study of people behaving differently to the same molecule is called the pharmacogenomics. I think we should take 2 more patient questions and we'll stop. Sandeep ji?
Last 2 questions are there, I think we can take.
Yeah, okay. No, there are many more. There are 24 more are there. But
No, sir. It's only
No,
2
so
last.
just 4 more questions are there. You can take 2, yeah.
Okay. So this is what is the pooled analysis? I said like last time, pooled analysis means when you want to do large number of population to study this, but we don't have the kids to do. What do? You take 5 people from a different families, 5 families. Take 5 families or 5 homes in a community, and one person from that community takes the sample, and all the samples are pulled together. That's why it's called pooled analysis. Pulled together, and that is sent for analysis. So single kit is used by 5 patients. If you find that the test is negative, you can presume, hoping that you've done properly, your collection right is perfect. That is taken into consideration. If that is done, and then the test is negative, that means you have no outbreak in that particular, those 15 or 16 people that you tested. Actually tested 5, but you project this and the meaning for those next 15 patients. It is the one is the time saving and the cost saving mechanism. This was done in Andaman Nicobar and also done in Germany. Germany also did a lot of work like this, doing pooled analysis, and could do good number of testing. You can do large number of testing in a short period of time, and you can get results also quickly. It's a good understanding. It not only takes into care of the economics, but also a scientific understanding, and gives you a short answer very quickly. And if the test is, then you have to do all those 5 tests individually again. You have to test. Then next question is, does hot steaming inhaling helpful to contain? Yes, again a good question. These are some of these studies which are called as the good lifestyle. For example, if you see in Nordic countries, Finland. Yesterday I was listening to the interview of Finland, and Finland has contained the infection extremely well. And how they could do it? They could do this because they have what is called a sauna bath. Sauna bath is that you take hot bath at a high temperature, then suddenly you take a cold water bath, again you take hot water bath, again you take a cold water bath. It has been scientifically confirmed and proven beyond doubt that when you do this, exposed to hot and cold, it brings about the stimulation of mast cells and also the killer cells. So therefore, it boosts up your immunity. And needless to say that in Finland, we have the least number of cases. They have hardly about some 90 deaths. That's all in that country. So they have very less data. They've contained extremely well, probably because they have this practice of sauna bath. So could be what you're saying is right, that steam inhalation or taking a sauna bath has a good impact. The next question, sir, if I understood correctly, the vaccine production started in US on 8 January and Jennifer is on 10 January. No, it is, she received somewhere in the month of March. 8 January, it was the work began. I mean, the virus was isolated. 10 January, the work began. And she took somewhere in the month of March end, almost March end. That's when she took that vaccine. So this is I'm sorry if I communicated wrongly. It work started identified on 8 January and the work started on 10 January and they could make a virus by the end of March.
Yeah, the last question, sir. That's the last question.
Which one is this? Last question.
What is the maximum duration of hydroxychloroquine? Maximum duration of hydroxychloroquine.
For prophylaxis or for treatment?
No, sir. So the question is, what's the maximum duration of hydroxychloroquine and azithromycin treatment in COVID-19 confirmed patients?
Yes, this was given for a period of 10 days in the study done at France. In fact, the next study did only for giving it for 3 days and follow up these patients. But he saw, in the first study, he showed at the end of 7 days, the virus load has become almost zero. So therefore, roughly about 10 to 12 days is what you give this particular treatment. This is all empirical. It is not 100%. First of all, it is not recommended routinely. But if you decide to treat, you treat for 10 to 12 days. That is just again empirical. It has no scientific background, but you can do it for that duration.
Thank you, sir. I think with this, we have completed all the queries. There were around 25 queries from the different colleagues. Thank you for giving appropriately all the management protocols and the diagnosis protocols for COVID-19. Still, if there would be any query further, if we could get it, then we will forward it to you, and we'll need your help to solve those particular queries also. With this, we have come to the end of the today's session. And tomorrow again at the same timings, 3 o'clock Indian time, we are going to have the third session of this series. Wishing you all the best. Take care. Stay home. Stay safe. All the best. Take care. See you.
Thank you. Thank you very much. And Natasha, that question. How to get